Today's guest is Dr. Tristan Barber, a leading expert in HIV medicine, serving as a consultant physician at the Royal Free London NHS Foundation and as the Honorary Secretary of the British HIV Association. With over 20 years of lived experience with HIV, Tristan brings a unique personal and professional perspective to his work. His research focuses on HIV-related neurocognitive impairment, aging and fertility, and he played a key role in establishing the SAGE Clinic, a dedicated service for complex HIV care. In addition to his clinical and research contributions, Dr. Tristan Barber is deeply involved in education, advocacy, and shaping the future of HIV treatment and policy. I think you're really going to love this episode and getting to know Tristan. So sit tight, listen closely, and you might learn something. Thank you for joining me on the show. Really, really great to have you on here. I'm really pleased that you're with us, and I'm very excited for this episode.
Absolutely delightful for you to ask me to participate. Thank you, Christian. Really pleased to be here as well.
How could I not ask the infamous Tristan Barber? So I want to get into it and straight from the off. I want to know what inspired you. You know, what was that early piece of information that sort of motivated you to become a specialist within HIV and sexual health?
Oh, Christian, it's such a good question. I mean, I avoided it. I've got to be honest. As a gay man, I thought it was such an obvious choice to go into sexual health and HIV. I did my elective. You get this period of time at medical school where you can go overseas. I did my elective in San Francisco in 1998 in HIV medicine. I can remember it very well. There were adverts on the bus stops for D4T, which was a very early HIV drug with a lot of toxicity, Zerit or Stavudine. So I was getting the bus into San Francisco General, delivering, supporting HIV care, not delivering. Of course, I was a student, but wonderful people working really hard in a very difficult environment, attempting to socialize in San Francisco, which was still reeling from the effects of AIDS and all of the trauma that had caused, struggling to meet people, actually, because there was a gulf, I think, when you were a teenager or in your, as I was then in my early 20s, there was a gulf between you and men only 5 years older who'd, lost people, been bereaved, really lived through difficult times. And then I came back thinking about HIV as a career vaguely, but actually thinking, let's do something more acute. Let's do something that's a surprise to everyone in terms of career choices back in the 90s. And so I started off in obstetrics and gynecology because I loved women as patients, much more in tune with their bodies very often. And I loved labour ward, but I quickly realised I was not a surgeon. And after a few other career choices, I had a 6-month gap and I ended up in a sexual health and HIV job at Barts in the London, in the Ambrose King Centre. And it was just fantastic. I just met the nicest people. I was working with a team of people where it really felt like coming home. We had huge waiting times in a swelteringly hot waiting room with a male and female floor back in the day when we separated men and women into different clinics. And just loved it. Talking about sexual health, being open, being inclusive of people with their whole range of diversity and protected characteristics, working in an area of London that had huge ethnic diversity, lots of stigma and shame around sexual health and HIV. And I just loved it. As I say, it really just felt like coming home. So after that, the choice was set. I had to undertake the necessary postgraduate training, and I've now worked in HIV and sexual health consistently since 2004. So for 21 years, and really motivated by the people that you meet and their stories and the fact that you can make people feel at ease about something they're often deeply uncomfortable about. And now how lucky we are with modern HIV treatment. We can offer people a normal life expectancy and excellent health-related quality of life. Yeah,
amazing. Incredibly well said as well, thank you, by the way. So I think, to give the listeners a bit more perspective, within the world of HIV, you wear two hats. You yourself have been living with HIV for 20 years and also working as a healthcare professional within HIV for the last 21 years. Help me understand how that sort of personal experience has influenced your approach over the years.
Yeah, so thanks. I was diagnosed with HIV in 2002. I knew that I'd acquired HIV. I was really sick. I had an HIV seroconversion illness. I enrolled on a study at St Mary's. It was the open label seroconverter study. So I was put onto treatment immediately, which was not the standard of care at the time. It was a short course of treatment. Of course, you have this idea that maybe you're going to be cured by this research at the time. So I was quite devastated when I interrupted that short course and my viral load went back up. But my lived journey with HIV, I think I cannot separate from my practice in HIV and sexual health, my research in HIV and sexual health. It is, I'm not going to say it's a unique perspective. Of course, there are other people living with HIV who work in the sector. But I think what's been really interesting for me is that in the early years, of course, and I think this is true of any junior doctor, you keep your personal life and your professional life very separate. So in my head, there was probably a little bit of splitting. There was me, Tristan, having my weekends, having my time outside of work, dealing with my own mortality, my own medical diagnosis, my own interpersonal relationships, just like everyone else. And then there was career me, who was like everyone else, getting on with my career and my training. What has been more interesting to me is that in the last 5 to 10 years, since I've been in a senior consultant role, your personal and your professional, I think what happens when you're in a senior role in medicine is you're able to bring more of your personality into your practice of medicine anyway. When you're a junior, now a resident doctor, you're doing what the boss says. You're following, you're towing the line. You're following what your consultants want to do. When you are a consultant yourself, of course, the way that you practice medicine can involve more of your own personality. You've done the medical training, and it now becomes about how you want to not steer the ship, because it's really the people that you're looking after who steer the ship in terms of person-centered medicine, but bringing more of yourself to that. And for me, that has really been a virtuous circle in terms of course, I'm looking after people with HIV. I don't disclose my HIV status to everyone I look after, but if they look online, they would easily find that I'm quite open about it. But for the people where it has been relevant to share my status, that has really helped them, I think, in terms of their own journey. So I think it is a unique double hat situation sometimes. But it really reminds me of the fact that any doctor, regardless of their own personal circumstance, or any healthcare practitioner actually, is there for a reason. They're there not only because of their training, but also because of who they are, what their personality brings to the job. And it just happens to be that HIV is part of my personality and my personal journey. And being able to incorporate that into the way that you practice holistic and person-centered medicine has been an immensely positive, privileged, and important position to be in, I think.
Yeah. Thank you for that. I appreciate it. So over the, I've done my research and I've looked into, some of the key achievements and really standout milestones, that you've been able to do over the span of your career. Are there any of those that have sort of significantly impacted your professional trajectory? And if so, which ones sort of were they?
It's a really good question. So I've loved my career progression within the UK. We're lucky in the UK. We have this unique specialty of sexual health and HIV. Most HIV care around the world is delivered by infectious diseases specialists. In Europe, sexual health is delivered as a combined specialty of dermatology and venereology, so skin and sex, basically. Whereas in the UK, we have this unique sexual health specialty where we also deliver HIV care. So I have loved the training that I've undertaken in the UK. But I think if I consider the pivotal moments for me, because the UK, working in the NHS for nearly 3 decades now, it's quite institutionalized. There's a stepwise progression to your career, which is in some ways reassuring and in some ways a little bit stifling from time to time. The really important thing for me, and I think one of the reasons, going back to your first question about why I ended up working in sexual health and HIV, is that you start to realize not only do you have an impact in the UK, but you can have an impact globally. HIV is a global epidemic. We're very lucky in the UK that we have free access to HIV care for everyone. We have free access to antiretroviral therapy. But the ability for me to engage globally and to go to other country environments, either to deliver education or to support people delivering clinical care, is really, I think, those are really the moments when I thought, wow, this is amazing. Not only have I been able to train in a fantastically safe and secure environment, but I'm able to go out and support and train people where it's much tougher. So I have worked in South Africa, in KwaZulu-Natal, working with adolescents with HIV who had perinatally acquired HIV and were transitioning from pediatrics, so from childcare to adult HIV services. I've worked in Nepal. I spent 2 months in far western Nepal in 3 HIV clinics, supporting and training rotational doctors there about HIV care. And I'll never forget the day that I first arrived in one of the towns that I was working in, and the doctor was very new, and she said, "Oh, great, could you please come and see a patient on the ward? I think he's got pneumonia. I don't know what's going on with him." And we went to see him, and she was treating him for bacterial pneumonia, and it was very clear that he had pneumocystis pneumonia, which is an AIDS-related complication. And she felt devastated. She'd not thought about it, but she hadn't been adequately trained at that point to be working in a remote situation with very little support. And so the ability to educate in that environment was just amazing. I've also been very lucky to work with a colleague, Mike Ewell, who ran a not-for-profit educational organisation called Just Thrive for many years, where we worked in Southeast Europe, Eastern Europe, and some countries in the Middle East and North Africa, delivering education there where there's a huge amount of HIV-related stigma, very fragile general healthcare systems, and really developing, I think, that global network that's based on the fact that I have a UK job with my UK training, but have the ability to go out and deliver education and support clinical services in other country environments. I think those have really been the moments that solidified and secured the fact that I really felt I've made the right choice.
Yeah. And look, and I can tell you from, an outsider coming into this, 2 things really. One, when I've gone to sort of, the medical conferences like the British HIV conference and other such conferences, I really, probably more so than anywhere else I've ever been, I really feel that sense of community and about how every individual who is there is all working towards a common goal and fundamentally trying to improve the quality of life and patient care around the world. And I can see that coming in, and I'm by no means a healthcare professional, but that is really that really stands out. And then I think that the second thing is that and you may or may not have noticed this, but just how well regarded you are. I think that really shines through. When I see you walking through the conference halls, I could probably say that you get stopped about 5 times before you make it to the cafeteria or the coffee or whatever it might be. So I think, that sense of community and being able to provide that impact and I suppose full circle, how that makes you feel as well, and being able to feel that you can add value.
Do you know, I think the hardest thing about that is probably maintaining your, your personal, professional balance, your work-life separation, because increasingly I can't separate them. The HIV gum crowd are they're my family, they're my friends, they're people you've spent formative experiences with, they're people we talk politics with, they're people that we advocate for marginalized communities with, and of course I've got my friends outside of my job, but the fact that I don't think I anticipated this. It's really, I remember being at medical school and thinking, you have to go through a lot of frustrating stuff at medical school, and you never would imagine the place that you can get to. And now I'm a personal tutor at the Royal Free for UCL Medical School, and of course the medical students having all the same issues I had. They're worried about the future, they're worried about the NHS, they're not sure of where they're going to go, they're not sure whether they're going to become the doctor that they want to be. And you don't want to be the person who says, oh, just wait 30 years and you could be like me. But it is like, I would not have believed, had I told my former self that I would be in this authentic position where I could share my personality, use my training to advocate for good, be engaged in creating some political change. We've done a lot of advocacy work for numerous regulations around limiting careers for people with HIV. We've changed the law recently for people with HIV who want to donate sperm or eggs to create a family. So yeah, the authenticity takes a little bit of time. That's what I would say. The authenticity takes a bit of time to come through. And then when you can be your authentic self, going to work related events, and they are work, Christian. I hope you didn't just make everyone think that conference was just a party.
Just to be clear.
But go there and see lots of your colleagues who are friends, talk about shared goals, share research that everyone has done, talk about advocacy work. Yeah, it is soul warming. It is soul warming. And I often say that medicine is a bit morally lazy because we turn up, we get paid, and everyone thinks we do the best job in the world. We don't try and kill anyone. We don't try and extort anyone. We don't try and make money out of people, but we get paid pretty well for public sector workers, I can't deny. And so we're kind of in a sweet spot. We do stuff that makes us feel good, that other people value, and we get paid for it, but we do work very, very hard. And yeah, I honestly, if I could say this to my former self, I'd be very happy, because you come into a place where you can feel authentic, you can change things, you can deliver good care, and you can be surrounded by people who are doing the same. And that is, I don't know what else you would want out of life.
Yeah, that is fulfillment box ticked, I believe. So what I want to go into now is I want to understand your areas of focus within your sort of clinical research. And there's a number of projects that you sort of led the way on. One of those being the Sage Clinic. And I think if you just help me and the listeners understand, what is Sage Clinic, and what does it set out to do?
Sure. So the Sage Clinic is a dedicated ageing and frailty service that we set up at the Royal Free in 2019 for people living with HIV. I think one of the things we are guilty about in the HIV sector is often some mixed messaging. The first mixed message I can always think of is the, protect yourself, use PrEP, wear a condom, don't get HIV, it's really bad. Mixed alongside HIV's fine, you can have a normal life expectancy, test regularly, know your status, and everything's good. And of course, in reality, both of those things are true, right? So we don't want anyone to get HIV when you can protect yourself from getting HIV, but it's much better if you have acquired HIV to test, to know about it, to take treatment. We can keep you really well. You can have a normal life expectancy. You won't transmit your virus sexually when you're on treatment. So really, we need to show the whole range of the HIV messaging rather than having these sort of two binary opposing views that I think leave people a bit confused. Which is it? Should I not get it? Is it all right to get it? I don't know.
Yeah.
And I think the other thing that became very clear to me is that a lot of the press around HIV was about the successes, the falling rates in gay and bisexual men who have sex with men. Fantastic. Absolutely needs to be celebrated. The fact that for a lot of people, one pill once a day is effective treatment, also fantastic. Really good news. But it wasn't reflecting the lived experience of the people who were diagnosed, let's say, before 1996, before we had triple therapy. These are people who were told to cash in their pensions, sell their house, do the bucket list, told that they had a 5 to 10 year life expectancy, and were given super toxic drugs that have legacy side effects that have affected their nerves, they've affected their body fat. A lot of them have got post-traumatic stress disorder because their loved ones or their friends died and they weren't sure if they were going to die. So you've got these two realities. You've got falling diagnosis rates in gay and bisexual men in central metropolitan areas who access pre-exposure prophylaxis. And then you've got this pool of people who've been diagnosed for 20 or 30 years who say, well, that's lovely, but it's not me.
Yeah.
And my journey with HIV has been different. And I really felt those people needed some attention. And what we do know is that although people with HIV have a normal life expectancy on the whole, people do suffer earlier or more severe comorbidities. That includes cardiovascular disease, it includes some cancers as examples. It also includes diseases that affect other organ systems. And there are enough people living with HIV in the UK that we will change the screening guidelines for most of these problems. What we need is HIV specialists who look at these people and say, you are doing well, but we do see a bit more premature cardiovascular disease in people with HIV. Your GP wouldn't necessarily be looking out for it because they might believe, as a lot of the general public do, that it's one pill once a day and it's all fixed and your viral load is undetectable. What we know is that's half the story, but actually we still need to have a specialist lens to look out for the things that might occur earlier or with greater severity. So SAGE is really about people that are aging with HIV with complex comorbidities, complex prescribing of additional medications, or are developing premature frailty. And I've got to hand on heart say I delivered this service at the beginning. I was very lucky that a geriatrician who was training, Dr. Hal Jones, knocked on my door one day and said, I'm at the Royal Free because I wanted to come and deliver services for people with HIV who are aging. So I said, come in, sit down. And increasingly, Hal is now running that service. So I'm giving HIV advice, but we have a geriatrician, not that he's only seeing people that are old. We see people 45, 50 and above who might be developing some of these complex issues. And he gives them a comprehensive geriatric assessment, discusses their HIV care with me. So we do it really as a pair. There are other similar services. There's the Silver Clinic in Brighton. Chelsea and Westminster has an ageing service delivered by a geriatrician in addition, and other services around the country are starting to see this very much as an important area, mainly because we now have over 50% of people in the UK with HIV are over 50. But for me, it's not just about their age, it's also about how long has their HIV journey been. And if they were diagnosed before 1996 or they were diagnosed before 2005, before we had well-tolerated HIV drugs, they need a specialist lens to look at what's going on as they get older.
Yeah, for sure. Because somebody who's 50 years old could have been diagnosed 2 years ago. So whilst they are aging with HIV, it's not the same. There's a lot of different nuance that needs to be taken into account. So yeah, I totally understand that. And with sort of that collaboration, that international collaboration stuff in mind, if for any sort of healthcare practitioners listening to this who also want to sort of develop this area of care, what kind of advice would you give to those people?
My advice is really simple, actually. So what we tend to do in HIV is we tend to check people are taking their HIV medicines, they don't have any new HIV related problems, and we check them for some of the problems we know occur more frequently in HIV. So anal cancer, cervical cancer, make sure some of those things are done, that they're vaccinated with necessary vaccines. I'm simplifying it a little bit. We follow the British HIV Association monitoring guidelines, and we do a lot more than that. But what we don't do is take just a general medical history because we don't have time. And my basic advice to people when they're looking at developing this kind of service in a cost neutral way is know your own cohort. So that you've got people that are stable on treatment, that have no issues. They might be young. Some of my younger patients are very stable. And those are probably people that can come once a year. They can have a viral load. They can get their medications. They might check in with the nurse in between. They might check in with the nurse in 6 months. But, they're the people who are HIV literate, digitally savvy, well connected, no other people with HIV. And they're like, I'm fine. I don't need anything. All I need is my meds. And then you have the people are complex, and you need to give them more time, because most HIV services will give people a 15 or a 20-minute appointment across the board. Yeah. And for me, what I'll say straight away is know your cohort, give the stable people a 10 or 15-minute appointment, and you save the time, and give the complex people a 40-minute appointment. And rather than just talking to them about HIV, take a comprehensive geriatric assessment is really just a general medical history. So go, put your head back to medical school and start asking them about everything else. Ask them about continence, ask them about sexual function, ask them about cardiovascular and respiratory symptoms. Just go back to basics. And you'll be surprised what you pick up when you take your lens away from HIV and look at their general health. So buy back some time by stratifying your clinic a little bit and give some people, the most complex people who need it, extra time. That is the simplest way forward for me. Nothing more complicated than that. You don't need a complicated screening tool. You don't need a complicated test. You don't need a complicated scan. You just need to give older people or people that are more complex just a little bit more time and ask them about all of their general health rather than just their HIV.
Yeah, good. That real holistic approach, and I think I think it was Chloe Orkin who I heard say that first at one of the British HIV conferences, and I was like, yeah, that's really refreshing to hear, because I've also been a generalized patient with my general practitioner, and it does feel kind of, at times it can feel just like really short, and I've got a bit more to give, and I want to sort of explain that. So I think applying that strategic, having that strategic approach really does help, certainly for the people who really do need it. Another area and focus area, from what I found in my research, is of yours is neurocognitive impairment. Did I say that right?
Yes, very well.
So can you sort of elaborate on that? Explain to myself and listeners what that really means.
Yeah. So neurocognitive impairment is a reduction in your usual brain function, essentially. And we know that HIV has an impact on the brain. We used to see people, before we had successful treatment, we used to see some people develop an HIV-associated dementia, which was really serious, really horrible, really debilitating. Wow. Since we've had successful treatment, there's always been this kind of idea that, is HIV still doing something in the brain? Does it do something when you first acquire HIV? Or does it continue to do something even when you're on successful treatment? And it's a really difficult question to answer, because when you look at someone's cognitive function, of course, there's a whole heap of other factors that can contribute. Your educational status, your socioeconomic status, whether you smoke, whether you drink alcohol, whether you use recreational drugs, chronological age, HIV therapy, just a whole heap of different things that can contribute. And you get into, it's quite difficult with the HIV community globally when you talk about this issue, because some people are very wedded to the idea that HIV continues to cause premature cognitive decline, whereas from the other side, we're trying to very much normalize HIV and say, people can do very complex jobs, they can fly airplanes, they can be surgeons with HIV because the treatment's so successful. And I think where I became frustrated was there have been hundreds of millions of research dollars spent in the last 20 years looking at cognitive impairment, and nothing has translated into clinical practice. So we don't have a routine screening test in clinics that's validated in people with HIV. We don't have a clear intervention that would make it better if there was a cognitive signal in HIV. We don't know the natural history of whether HIV cognitive impairments progress when you're on successful HIV treatments. There's all sorts of unknowns, and there's a lot of worry and there's a lot of anxiety. So my research was really trying to say, what can we deliver in clinical practice that might be helpful in this area? And I have to say, I struggled to find any definitive conclusions, but in the cohorts I looked at, we did not find an excess of HIV-related cognitive impairment. Now, the flip side is that now, of course, I've mentioned that people with HIV are aging. So the question now really should be, I think, not does HIV cause a problem, but which it probably does in a small minority of people, but probably not for the most. The question should really be, do people with HIV get premature aging-related dementia? Do they get premature Alzheimer-type dementia? Do they get other dementias? And those are very different types of dementia. Like, they're very different. They need a different way to screen. They need different tests. It's not the same as looking for HIV, which causes a different pattern of dementia. So I still feel frustrated. I'm not sure my research has given us any definitive answers. In fact, I know it hasn't. But I feel like we're asking the wrong questions. We're not looking at holistic care for people with HIV and cognitive impairment. What a lot of people with research are still trying to say is, does HIV cause a specific type of dementia? I would like to get rid of that question. I would just like to say, do people with HIV do develop dementia earlier? And if they do, what can we do about it? Or how should we pick it up?
I mean, again, this is probably oversimplifying, but with that sort of holistic approach in my mind, asking the the person in front of you, are you noticing anything, any changes, anything different like that? Is memory or focus becoming a bit of an issue? That would be that initial step. It's quite a broad question, but then you can start to dial down. Do you think that's the right sort of
So,
approach?
of course, it's Valentine's Day, Christian, and it's delightful to spend Valentine's Day with you. But thinking about who do you think normally reports cognitive impairment for most people?
That's a great question. Friends and family, maybe?
Yeah, exactly. It's usually the partner or friends and family. So it's usually not the individual who reports them themselves. It's the most common thing is that the partner will say they're not quite themselves. They're forgetting things, or they're not working if they have a partner, or they're not performing as well as they usually do at work. So yeah, having someone else who can give you a little bit of history is usually very valuable.
Really interesting. And again, this is a question from myself, me thinking during clinic, how is it a regular occurrence for people to bring a friend or a partner or a member of family with them, or is that not the case at all?
It's variable, but no, it's not that common. But even an individual will say, my partner says that I feel fine, but my partner says I'm not the person I was, or my person says I forget, my partner says I forget things, or my partner says I can't do the shopping anymore.
Yeah, my partner says lots of things like that. One of the sort of the topics that I really wanted to cover, and I wanted to get your view on. There's lots of developments, new developments coming out, from the pharmaceutical companies right now. One in particular is this long-acting injectable. What are your thoughts on it? What do you think that potential impact could be, on HIV prevention and treatment?
Gosh, we're so lucky in HIV. We continue to have amazing drug development. So we have injectable treatment at the moment that's given every 8 weeks. It's not suitable for everyone, and most people are getting 6 months of tablets. So a lot of people say, "Why? If I'm coming in twice a year, why would I want to come in every 8 weeks?" We've got trials starting at the moment that are looking at weekly tablets, and a lot of the community that I speak to are very excited about the idea of weekly tablets. Mm-hmm. And then we have this other injectable drug, lenacapavir, which is given every 6 months. At the moment, only available to people who've run out of other options. And the annoying thing about lenacapavir is that, of course, like all HIV drugs, you can't take it on its own. You need another HIV drug to be given with it. And we don't have another drug that matches that 6-month dosing schedule. So people who get the 6-month injection still, for the most part, need to take daily tablets in addition. I think if we got a matching drug, so if we got something else that matched it and could be given every 6 months, so 2 effective drugs every 6 months, that would be a revolution. I mean, if you could have a subcutaneous injection under the skin twice a year to manage your HIV, that would be incredible. And the other thing, of course, about lenacapavir is there's been very good trial evidence showing that it works very well as prevention. So 100% effective in an African setting in women, and that's now been repeated in gay and bisexual men who have sex with men. 100% effective at preventing HIV with 2 injections a year. And the problem is cost. So it's incredibly expensive at the moment in terms of its price in Europe and the USA. The company that make it have said they will be offering some kind of licensing for much cheaper rollout in low middle income countries. But for most people, accessing this drug is going to be very difficult. and mainly limited by cost. So incredibly effective at prevention, really useful in treatment, nothing to partner it with in treatment as yet, but nonetheless an exciting drug and lots of exciting data.
And if I were a person who is living with HIV, who is interested in maybe getting involved and trialing this, what would you say to them?
If you were living with HIV, did you say?
Yes. If you were thinking of
So
switching regimes, basically.
yeah, so at the moment we're very limited in the UK in terms of who we can prescribe it to. So you have to have very reduced options. You have to have almost nothing left that potentially could work. It's also available as a tablet form. It's in the weekly tablet as an example. So there are studies that will be available to people at earlier stages of treatment where they can access this drug, but really they just need to talk to their own clinic or clinician.
Okay. Now, I do want to talk and touch on stigma. And I really want to, understand some of your own lived experience. And also, understand maybe what sort of strategies you yourself and some of the strategies that you try to get across to some of your patients around maybe overcoming some of this, overcoming stigma and any sort of any effective strategies that you think, help people.
The really difficult thing with stigma is, most of it starts with yourself. And I think that's the really annoying burden that we place on people with HIV, because not everyone wants to be the poster person, banging the drum and trying to break down every wall in terms of HIV. So those of us with more agency and power try and break down stigma to protect people who feel more vulnerable. But ultimately, it's the shame that people carry within themselves that's the real challenge. And I find that the way to overcome that is to be open about your HIV status and challenge discrimination when it comes. But of course, for many people, that doesn't feel possible. I think some of the strategies that are useful, I think one of the main strategies is education, like with all of sexual health. We know that sexual education is still really poor in schools. We know HIV education is really poor. And what we really need to do is normalize testing. Everyone has an HIV status. It's just whether or not you know what yours is. We also don't really focus on education around sexual pleasure. We focus very much on sexual illness. And in actual fact, knowing if you are living with HIV, being undetectable, you cannot transmit your virus sexually. The safest person to have sex with regard to HIV is probably someone with HIV on treatment rather than someone who has never had a test.
Yeah.
So, promoting some of the positives, I think, around HIV and around sexual health, sexual testing, but then also sexual pleasure and well-being, not just sexual illness and sexually transmitted infections. I think if we could go back to looking really closely at education in this field, I think that would really help with stigma. And then back to the mixed messaging. We've been really poor at it because we didn't talk about HIV for so long. We had those horrible tombstone and death campaigns back in late 80s, early 90s. And then we got triple therapy and kind of HIV went away. So I think most of the general public still think it's either fixed or sorted or it happens to other people. It needs to be a normal part of regular healthcare. HIV testing, know your HIV status, access the benefits of HIV therapy, don't pass it on to your partners. These should be positives. It shouldn't be shunted away out of public consciousness, hidden. We now have opt-out testing in emergency departments in England, in many emergency departments. And the people that receive positive tests through that testing scheme are from groups that historically would not have thought that they were at risk of HIV infection, mostly. Yeah. And the people that I've seen who come and sit in my room with a new diagnosis of HIV, their ideas about HIV are 20 or 30 years old. And I actually think that's a failing of us and governments to educate people about where HIV is at, what the positive things are about HIV, and how useful it can be to test. because they've never seen HIV as being something they need to test for. They've never seen HIV prevention as something they needed to access. And so I think really it is about education, public campaigns, and normalizing testing, normalizing HIV as just another medical condition that it's important to protect yourself from, but also test for and get treatment for if you're found to be living with HIV. So I think really it comes back to a failure of education and public health information from government.
I think the opt-out testing, is being crucial, and the rollout across that is happening, more and more across the UK, and with with fantastic success. But I think, I'd love to get your viewpoint on this. How powerful is U equals U?
Oh, U equals U has been an absolute, this phrase is overused, but an absolute game changer in terms of normalizing sex, normalizing having a family, allowing people to work in careers like surgery and aviation. I can't think of a more transformative piece of research than the research that led to the U equals U statement. And I think for people living with HIV, just knowing that they cannot transmit their virus, having lived, some people have lived, the people I talked about earlier, the people that have lived since the late 80s or the early 90s, who lived a life fearful of transmitting the virus to their loved ones or to their families, or the fact that now you undetectable, you cannot transmit your virus, is really just incredible.
Yeah, I totally agree. A shout out to Bruce Richmond if you are listening, my friend. The trailblazer that he is.
Well, and Bruce is a very good friend of Alison Roger, and Alison Roger, who I work with at the Royal Free, who led on the Partner 1 and 2 studies, which really led to the definitive statement that U equals U. I think they're a great team. Alison having delivered the research, and Bruce gets that message out everywhere he can. And it's fantastic.
Bruce is everywhere. I see him across all platforms, every conference, everything. But yeah, kudos to them both. Have done a fantastic job, and it is, it is a game changer for so many people. One of my last questions that I have for you is around, what advice would you give to aspiring advocates? What sort of guidance would you offer to individuals looking to become advocates themselves, and within the field of HIV?
I think everyone's an advocate to a degree. And I mean people living with HIV, I mean allies, I mean people working in the sector. You're a fantastic advocate yourself, Christian, of course. I think people have to decide what level of advocacy they want to be involved in. I get that some people end up making a career out of HIV. I made a career out of HIV myself, and some people make a career out of advocacy in HIV, and it becomes their entire life. For some people, it's part of their life. Something they take their tablets for. Sometimes they forget their tablets because actually they've forgotten about their HIV, and they get on with the rest of their life as a parent or as a successful professional or whatever else they're doing in their life. For some people it's compartmentalized, and that's okay. So it's really about deciding what level of advocacy you want to be involved in, but never feeling that you're not an advocate. Whatever you're doing, if you're living with, affected by, involved in the HIV sector, you are an advocate to some degree, because you will usually be at least prepared to challenge disinformation. I think that's probably that's the basic level. These people are not deviant, bad, they cannot transmit their virus. Just getting those simple messages out can be a huge piece of advocacy in itself. So not everyone needs to be on a podcast, interviewed, campaigning on World AIDS Day. Advocacy sometimes happens in the small places. It happens with family, it happens with friends, it happens with work colleagues. And not everyone wants to make their life about HIV. Some people may do, and that's fantastic. And there are lots of great roles for those levels of advocates, but advocacy happens at home. But it happens, sometimes it happens on the small level, and that's where you really do change hearts and minds, in the classroom, with your family, with your friends, with your grandparents, with your work colleagues.
Amazing. To wrap up, I'm going to ask you one final thing. If there is one key takeaway that you would like the listeners to take from our conversation today, or just in general, what would that be?
HIV has driven an immense amount of change. It's driven discussions around sexuality, it's driven discussions around gender, it's driven developments of science in terms of drugs, in terms of our molecular approaches to virology. But the really important thing, I think, to remember is that HIV is just another medical condition. We should normalise living with HIV. We should normalise HIV testing. We should educate our children about it. We should educate those around us about it.
Mm-hmm.
People with HIV can live a normal life expectancy. They can deliver jobs in all aspects of career choices in places where they used to be limited. And really, HIV is no longer a limitation. You free yourself by knowing your HIV status, whether that's negative or positive. So test regularly, keep yourself safe, and keep those you love safe also.
Incredible. And you do a fantastic job of doing that, my friend. Thank you so much for being on the show. I really do appreciate it. I think the people who are listening and watching this are going to really appreciate it as well. So thank you very, very much, and keep doing what you do, my friend.